We have an extremely high percentage of our population that don't have family physicians. For those who do have family physicians, we have some of the longest wait times in the developed world for people to see their family doctors. I remember looking at stats around the time we started the company that more than 1/3 of Canadians waited more than 7 days to get an appointment with their family doctor when they were sick. In the emergency room, I was seeing people waiting routinely more than 8 hours for very basic needs to be met by me in the hospital. So they would sit in a waiting room for 8 hours, literally for 4 minutes of my time. And so I was very much struck by the fact that most of those people that were coming in and having that awful experience really weren't doing it out of some abusive nature of using the wrong part of the system intentionally or trying to take advantage of the system. They were there using the emergency room because they had nowhere else to go. They had no family doctor. They struggled in terms of after hours access when walk-in clinics closed. And so what was very clear to me at the time was that if only there was a way for those patients to access doctors like myself without having to sit in a waiting room, we could solve a lot of these issues that put a lot of strain on our healthcare system. And at the same time, what was very clear to me back in 2014, right before we started Maple, and we started the company in 2015, it was that none of my friends or family members were having those struggles when they needed immediate access. So when my friends or family members, when their kid was sick at 10 at night, or all of a sudden they had a sore throat at 8 p.m. or 7 a.m., they weren't going to the emergency room and waiting 8 hours to see somebody. They were texting me and they were FaceTiming me. And over again, I was pretty easily able to solve their issues in a few minutes by text or by FaceTime. And so there were a couple of things that became clear over that course of time. One was that, first of all, this kind of care just worked. I was really able to effectively diagnose people, to provide good treatment. They were very, very happy with the experience. I really enjoyed the experience, and it provided me a way to use time in my schedule that was otherwise unavailable. So as an emerge doc working a full-time set of shifts, which was about 16 shifts a month, I was pretty burned out and definitely was not ever going to pick up an extra shift. But for all those days when I was off shift, when, if not for the ability to help people virtually, I probably would have just been having lunch with friends or watching a movie or doing something else that wasn't going to help the healthcare system. I was actually able to add to my capacity. So the revelation that led to starting the company was, wouldn't it be amazing if we could give everybody in Canada, not just those people who were fortunate enough to have the right friend or family member who was a physician, wouldn't it be amazing if we could give everybody in the country that kind of access that felt like there was a doctor at their fingertips whenever they needed one? And I know we're speaking primarily about primary care today, and I think we'll dig into this a lot more, but one of the biggest issues I think in primary care, there's obviously the fact that so many people don't have a family doctor, which is a critical thing, and we need to take care of those patients. But I mentioned the stat about how long it takes for most people, even those with a good family doctor, to get an appointment. And so we need to fill gaps in primary care. We need to fill gaps for those people who have no family doctor at all. And we need to fill gaps even for those people who do have a family doctor, that when they have urgent needs, there's just no way for them to get an appointment in a way that is in time for them. So they end up in the emergency room, unfortunately, as a result. So virtual care is a really good way to fill that. We've done some amazing programs, which I can talk about in more detail, with some of the provinces out east in the Maritimes, where we actually combine virtual care and physical care for people without family doctors to give them effective coverage that spans both virtual and in-person care with continuity of records and a whole bunch of other features. And that's really a little bit of my story. So much more to tell, but I know that I'm about to hit my 5-minute limit. So I'll stop speaking for now, but I'm really excited to see where the discussion goes this evening. So thank you very much.
Terrific. Thank you, Brett, and right on time. So I'm going to turn next to Ewan Affleck to give us the sort of systems level perspective and the ways in which, frankly, in different parts of this country, if not the country as a whole, we've really struggled to provide good virtual options. So some of the pros and cons that you see related to the use of these technologies. Ewan.
Thank you very much, and thank you, Brent. And nice to see you as the little dot in the background, Sheryl. So a little bit about my history. I'm still work as a clinician, as acute care hospitalist at the Stanton Territorial Hospital in Yellowknife. But as was stated, I used to be the Chief Medical Information Officer of the Northwest Territories. About 30 years ago, I finished at McGill and I ended up in Arctic Quebec, and I was an experiment. I was placed in a remote nursing station on the Hudson Strait in in a place called Salawat, an Inuit community fly-in. And what became very evident to me was that I was terrified, first of all, providing care all alone in a little place without any other resources. And that I wanted to communicate with a lot of resources elsewhere to assist in my care. Our referral center was Montreal at that point in time, and but there was really, other than the sat phone and a fax machine, there was limited communication out. And that's when my fascination for virtualized services started about 30 years ago. And it's been a fascinating journey. Unfortunately, things have not changed as much as one would have hoped, and it really took a virus a few years ago to get most people interested. As you are all aware, the growth of virtual care was substantive, really, with the advent of COVID. For guys like me before, and people with startups like Brett and so forth, it was a struggle, I think, he's nodding. It's been a huge struggle to get any attention to this. And the thing that really drove me was an interest in providing more equitable, quality service to people, particularly in remote, rural, and northern Canada. So there's a few things I want to comment. Is really, as a country, we failed pretty miserably to embrace this technology historically. And where we find ourselves today is almost wholly unprepared to accommodate this. Our policy environment, our governance, and I think Sheryl will speak to some of this, our privacy laws, but also our approach to ensuring integrity of information that is shared between different platforms. And Brett, referred to interoperability, or how we can share information. This is a huge and dangerous problem that is impairing virtual care. So we as a country have been really unprepared, and I think we've done a pretty miserable job overall, and we're trying to catch up. I will say also that one thing that I do caution is, do not perceive the role of virtual care as being about providing access. Access is just one parameter of quality. You can provide a lot of access, but it can be unsafe, it can be inefficient, it can be ineffective, it could be so when the whole notion of virtual care has to embrace all the parameters of what we call quality care. And the problem is because of the dysfunction in the Canadian healthcare system, we're using a lot of virtual care to patch up our system dysfunction by providing access in a discontinuous and fragmented way, which is probably a bad idea. So I'll stop there. I don't know how much time I took, but I'll stop there.
Just about right on the mark. So good stuff. Sheryl, I'm going to bring you up then, using this miraculous 3D technology, and give us your thoughts on what we should be thinking about when it comes to virtual care and primary care.
Okay, so thanks again for having me here tonight to talk about this very important topic. I know you've had a long day, so we'll do our best to keep it interesting for you. So what I'm going to talk to you tonight about is based on research, some of it my research, but also the personal experience of my siblings who live in the Netherlands. So you can follow along. I've printed off some slides. As everyone here is aware, the government here in Ontario recently cut the funding to standalone walk-in style virtual care. So this left patients in the lurch who had come to value, who had come to use these services. But there were also good reasons why, or I understand why, the government decided to cut back on fees for funding that type of virtual care. They were hoping to disincentivize physicians from working in that model and encouraging them to provide virtual care within a comprehensive care model. Now, as Brett referred to earlier, even if all of these physicians who were Even if all of these physicians who are working in this model switched over from working in episodic virtual care to working in comprehensive virtual care, there probably would still be a good portion of people living in Ontario who wouldn't have a family doctor or nurse practitioner. And even those who do, as we know, a lot of them still struggle to get timely access. It's a fact. So does this mean we should continue to fund the walk-in style virtual care? So there's limitations with that approach as well. There's reasons that governments are concerned about it. There are reasons that health system administrators, researchers think this isn't the best model to provide care either. Doesn't provide comprehensive care. So you're not going to have a physical exam. They're not going to look after your ongoing healthcare needs, your chronic conditions. They're not going to provide screening for you. So it disrupts continuity of care. And there's a very strong association between continuity of care and health outcomes. Keeps people out of hospital, reduces mortality, and decreases health system costs. So there's a great benefit to integrating virtual care into ongoing care. And the other concern is too, not only does it disrupt continuity of care and not provide it, it might actually reduce the amount of existing comprehensive care that our health system is providing. And that's because physicians switch over from providing comprehensive care to work in these other virtual care models. There's a fixed pool of physicians. We don't magically have more of them. So if they're not working in one, or if they decide to work in another model, they're not working in the other one. So I know there's arguments that physicians find extra time in their day, but it's to me, it's counterintuitive. And unless we have evidence to support that, I wouldn't base any policies decisions on that. I would wait. If it does turn out to be true, then there's still the problem with the lack of comprehensive care. So there's still issues there. The other concern, and this comes from the research that I've done, is around privacy. How it happens to your health data when you use these platforms. So we received a grant from the Office of the Privacy Commissioner of Canada. We were funded to look at the data handling practices of virtual care platforms. Now, of course, they gather your personal health information, but they also gather a lot of other data as well. So they gather what they call, our participants described how companies defined it as sign up and registration information. Your names, your email addresses, phone numbers, things like this. Also your user data. So when you're accessing their web application or the app on your phone, they're gathering that information as well. They're also creating often de-identified PHI, so their health information, removing identifiers, and creating that other form of data. These data, according to participants in our study, there was 18 or so that we interviewed, all affiliated with these platforms, and this data was generally seen as being on the business side. So it was data that was used to improve and expand services, but also often used by many companies to market things, marketing their own products and services, marketing third-party products and services. Sometimes this was done by sharing your data, but often it was done just through telling these other companies what the demographics of the people were that were using their site, and then they want to do targeted marketing through your site. It was also very difficult for people to opt out of these data uses, and in some cases impossible if patients actually wanted to use often publicly funded health service. They had to agree to these terms of service. And then the other thing that we found through our research is that this may allow a way for more pharmaceutical industry influence over care. We found that some participants described how their platforms were taking money from pharmaceutical companies to adjust patient care pathways, the timing of visits, reminders, lab tests, all in order to increase the uptake of their drug or vaccine. And then the platforms would look at the data, adjust things, tweak things, and all to optimize the uptake of this company's product. So these are the problems. So we don't have a great solution here. We have two options that aren't great. In one, there's more comprehensive care, but these platforms don't exist. And then there's a large segment of the population that just doesn't have access to care beyond going to walk-in clinics or emergency departments. Or we say we are going to fund these type of platforms, encourage them, and then fewer people have comprehensive care, but then everybody has access to this in virtual care, which is problematic for all the reasons that I described. So we can debate that, and we probably will, but what I'd really like to do is present a vision another way, a way that everybody can have a family doctor or nurse practitioner, everybody can have same-day access for urgent issues, and have after-hours care as well. And it's not just a vision, it exists. My brother and sister live in the Netherlands, and like 99% of the population there, they have a family doctor. So I talked to my sister about what was her experience when accessing care there. So she goes to her family doctor's website. She can communicate with by email. She can upload photos. She can book appointments there. She can book an urgent same-day appointment. If she can't, for some reason, book it because there's no spots left, she calls the clinic and they find a way to fit her in. Anything else that she does? Oh, she can also renew her medications through that website. So she doesn't have to wait for the physician to get back to her. She can automatically renew things as long as it's not a narcotic or some other kind of controlled substance. Then after hours, between 5 o'clock and 8 o'clock the next morning, if she has everyone hear me still? If she has an urgent issue, she calls this number, and it's a number for an after-hours service. And there's a triage nurse who answers the phone, and they decide if she needs to be seen in person, if a physician could come to her house and assess her. They actually have that there. It's really nice. Or if it's something that could be handled virtually, or if it's something that should be deferred. So when she sees her family doctor, the next day, it could be dealt with then, or she should go to the emergency department. And this clinic is run by all the family doctors in the area. So they all pool together. They have a requirement to do a certain number of shifts there, an obligation to keep their license. They have to do so many hours of after-hour care, and they rotate through that clinic there, and they look after people. And also the clinic is at the hospital, so if you show up there and they're like, oh, you actually need to go, be seen in the emergency department, you just step next door and there's the emergency department. So it's very seamless. My sister didn't intend to stay in the Netherlands. When she went over there to do her master's, she ended up staying. This may be one of the reasons that she ended up staying there. Like, their care is it's primary care there is great. So how do we get there? We're in a different context. So on the next page, I put what I see as some steps to get us there. One thing is accountability. We need to be accountable. We need to have primary care accountable, probably to the Ontario Health team for that region, to say and to ensure that everybody has a family doctor, that everybody has access to urgent appointments same day, and that there's an after hours availability as well. So we also, of course, need capacity and resources for that. Canada, compared to other countries, spends a smaller proportion of its funding on primary care relative to other things. We should shift that a bit. Other things that we can think of, maybe more family doctors and nurse practitioners, but also different ways that they practice, so that they practice in teams. A lot of nurses and doctors report that they're doing things that don't use their skills appropriately. So if we get other people on the team that are doing those things instead, and they also report that there's things that they're doing that are outside of their areas that they're skilled at. So that's why a team system might work really well for that. We need to address paperwork. I can get more into that, but it's completely changed compared to when I started practice 15 years ago, how many hours I spend on paperwork. We need to address that too. We need to think about compensation. So apparently there's a third or so of family doctors that aren't practicing primary care, comprehensive primary care. Why is that? We need to make sure that it reflects the complexity and the difficulty of the things that primary care doctors do. Support for after-hours clinics. So in the Netherlands, this is actually funded through the health system. They provide the location at the hospital, the nurse, the ability for the one physician who's driving around to see everybody. This should be provided through the health system because it's going to save the health system money. It's going to end up being a lot cheaper. And rural and remote, we need to think about how that would work there. Probably more nursing stations, more virtual care, maybe one physician more centrally, nurses doing the assessments peripherally, and how that could work as well. And a lot of rural locations already have that set up, so we can learn from what they're doing. And legislate interoperability. I don't think there's any other way that it's going to work. There's so much incentive for companies to hold on to their data. So unless you have a law like they do in the US that requires interoperability, it's just not going to happen here. And we also need better privacy protections. And I think that's it.